Hello, and welcome to the Clinical Care Options Infectious Disease podcast. I'm your host, Jessica Adams. In this episode, we will be hearing considerations for optimizing antiretroviral therapy in the setting of viral suppression, specifically to address internalized HIV stigma. I'm joined by Dr. Gregory Huhn from Rush University Medical Center and Cook County HIV Integrated Programs in Chicago, Illinois. For more information about this program and to follow along with the slides, and also to register for one of our live sessions in this series, please visit the links in the show notes for this episode. And to get access to all of our new podcast episodes, subscribe to the CCO Infectious Disease podcast on Apple Podcasts, Google Podcasts, or Spotify. Now let's get started and hear from Dr. Huhn.
When we start with the WHO and this global strategy as far as how are we going to address HIV, in the US, we have Ending the HIV Epidemic as the initiative for the global strategy for WHO through 2030. The focus is to reach those individuals most affected and at risk and to address these inequities. And we do this through a holistic and a person-centered or people-centered HIV care approach. And really, we're looking for that long-term well-being. Health-related quality of life, this has been called the fourth 90, after 90% being identified, diagnosed, 90% on ART, 90% undetectable. The fourth 90 is really that health-related quality of life. Multiple morbidities, non-communicable diseases, mental health. Again, as our patients age, as they are undetectable for HIV, their HIV is under good control, we need to look to see how are they enhancing their overall life with other, perhaps, comorbidities of aging. And absolutely, we need to address stigma and discrimination. In fact, for Getting to Zero campaigns, particularly in, let's say, San Francisco, it's 0 new diagnoses, 0 new deaths from HIV, and 0 stigma. Very important. They've been on the vanguard for addressing stigma within our patients. And these 5 pillars here, this vision for long-term success, certainly getting to undetectable, that's the main focus for our HIV goal, sustain undetectable viral loads. But then what do we, or how do we approach the usual type of care, the clinical visits? Many patients say they may see that there's excessive clinical visits. This has been identified as a notable burden living with HIV. So our outcome would be to minimize the impact of treatment and clinical monitoring, to take sort of the medicalization out of our patient care, maintain that optimal health-related quality of life, as I mentioned, that fourth 90 to optimize quality of life in our patients as they age. Consistency of care among different healthcare providers was identified as a key factor in improving health outcomes. So again, that lifelong integration of healthcare, we work as a unified system, really from when the patients just hit the door to the reception, on through the triage, the nursing, the clinical visit itself, the lab, benefits, case management. We work as a single unit welcoming that patient each and every time. And then finally, again, stigma and discrimination, identified as key barriers for achieving optimal health outcomes for persons living with HIV. And our goal here absolutely is freedom from stigma and discrimination. So here's our case. There's a 42-year-old man, cisgender male, and he was diagnosed with HIV 1 year ago. So he started on bictegravir, FTC, TAF, this single tablet regimen since diagnosis. He's been adherent to this single pill once every day, but he says that this reminds him of his HIV every day as he's taking his pills, or just this one pill. No other past medical history or chronic medication. He's had some immune recovery with the CD4, which is quite good at baseline 438. Currently now, 1 year later, 520. It's over 500. That's where we want to be at. He's undetectable now from baseline viral load of 57,000. He did have a transmitted K103N as a non-nuke mutation. Baseline mutation affects viral fitness. He's a subtype B is for Hep B status. He's immune. No history of exposure, core antibody negative. Hep C negative, creatinine is fine, actually normal. LDL, HDL are also within the normal parameters, and his BMI actually, he's got a healthy BMI. He has gained a couple of kilograms since his diagnosis, but really under 25. All right, so reasons to consider optimizing ART in the setting of virologic suppression. And again, simplifying by reduced pill burden, enhanced tolerability to avoid that short-term or long-term toxicity, mitigate drug-drug interactions, eliminate food or fluid requirements. But here, where we're addressing long-acting antiretrovirals, this can relieve that pill fatigue, decrease potential stigma or disclosure concerns with taking your meds every day. Again, Other reasons allow for that optimal use of ART during pregnancy or with women of childbearing age, and then to reduce cost as well. But here we're going to focus in on long-acting agents. And the evidence that this can reduce internalized stigma. So even before the rollout, before long-acting antiretroviral therapy in 2019, this is a survey in Germany. In very high rates, people perceive stigma from their daily oral ART, 83%, 78% stressed by daily dosing of oral ART. When you're younger, less than age 50, 70% were among this survey. And again, they really sort of zeroed in on among this predominantly newly diagnosed cohort, 84%, really felt that if they could transition, and we've seen this in the phase 3 studies, to long-acting cabotegravir rilpivirine, this has been described as freedom, a logistical freedom from taking pills on a daily basis, and the psychological freedom, which is very important. Again, addressing stigma to lower that degree of stigma so patients can feel really kind of liberated and not really think about their HIV on a daily basis. And then when we take a look at the SOLAR study, so this was actually a phase 3 study where patients were virologically suppressed on bictegravir FTC-TAF, similar to our patient, and then randomized to continue their oral ART or to go on to every 2-month long-acting cabotegravir and rilpivirine. Most of these were straight to injection, actually. So virologically, this was non-inferior. Both arms did quite well, over 90% virologically suppressed as a stable switch study. But 47% reported going into the study that they often had fear of disclosure and adherence anxiety, again, that daily reminder of taking HIV. And then at their preference, after 1 year, overwhelmingly 90% actually preferred, if they were randomized, to stay on that long-acting antiretroviral therapy. And then the most common treatment satisfaction questionnaire, the HIV TSQ, at 12 months, again, statistically significant, improved satisfaction overall for patients that were randomized to long-acting therapy versus those that remained on their oral therapy. So the optimal candidates, really, they're virologically suppressed for at least 3 to 6 months on their oral regimen. They're engaged with healthcare. They will need to make those Q2-month appointments for injections. And there is a little bit of flexibility where you can actually have 4 weeks beyond that 2-month set point where you can still pick up where you left off. But again, need to be mindful that they need to make more frequent visits for these injections. Contraindications cannot be resistant or have background resistance to the component. So prior INSTI or non-nuke, except for the K103N, which is first generation non-nuke, nevirapine. Efaviren's not going to be a factor, not going to render that rilpivirine actually resistant or inactive. No prior virologic failure. And then occult or chronic hepatitis B. There's no, again, tenofovir agent here, no 3TC, FTC agent. So we don't want to risk losing control of a Hep B moving on to long-acting antiretrovirals. So what about the setting of viremia? There's more emergent data to consider this, actually. So the International Antiviral Society USA says may be considered for people with viremia unable to take oral ART at high risk for HIV progression. And really, this is a quite newer type of recommendation beyond just the indication for those that are virologically suppressed, considered for those that are viremic, with really kind of that may be the last frontier. Those patients that cannot be controlled on oral ART, LA-ART would be an option. So risk factors for virologic failure, and this has been vetted through multiple phase 3 studies, Atlas, FLAIR, Atlas 2M, with post-hoc analysis at week 48. Very low confirmed virologic failure rates overall, really 1.25%. But the factors here are the baseline rilpivirine resistance. Overwhelmingly odds ratio, if you have a baseline resistance to rilpivirine, 40-fold higher risk of failing than without the baseline resistance. HIV subtype A6 or A1, and primarily A6. We've seen this in Russia for the most part. A1, we just had a trial presented at CROI called the CARES trial that A1 was not a factor. And then a BMI, small factor, 13% increased risk, a BMI 30 or greater. And really, you have to have 2 of these. So 2 risk factors are needed for that significant increased risk. So again, expanded multivariate analysis through week, now we're at to 4 years of Atlas, from FLAIR, 3 years into Atlas, and then 3 years into Atlas 2M. It really validates that the baseline rilpivirine resistance mutations, subtype A6, A1, the most predictive factors for resistance. And so if there's sort of clinical equipoise. If you really don't know maybe what their background of resistance was, you don't have the genotypes, maybe they failed prior regimens, maybe they've been on non-nukes, that's the time, if they're virologically suppressed, that you should probably get an archived genotype. And it may be less sensitive than the cumulative RNA genotypes, population-based. There may be discordance. In this study, the GenPro study, among persons with previous 3TC resistance, population-based sequencing, that's the sequencing we do when their viral load is 400, 500. This is the routine genotypes. They detected 3TC mutations in only 27% of patients that had prior 3TC resistance. So you could actually lose that resistance years down the line when you do this population-based sequencing. So the DHHS recommendations, again, no prior virologic failure on their first or second regimen, or their genotype results, again, show no prior virologic failures, unlikely to give you any information if you were to go for a proviral genotype, DNA genotype. But as I said, complex, semi-complex, pre-existing resistance suspected, regimens you may not have reports, this may be useful. Again, with caution, may not detect all drug-resistant mutations, particularly those selected by previous ARV regimens. We saw that with some M184 that may have been lost, again, years down the line, being virologically suppressed. And again, it may identify mutations that may not be consistent with the prior response to treatment. So some caveats there. So again, as sort of a wrap up here, no proviral DNA genotype was performed. He was on his first regimen, virologically suppressed on BIC/FTAF. He switched every 2 months. He was subtype B, no evidence of rilpivirine resistance or failure, hepatitis B negative. He's monitored now for maintenance. Again, looking at, is he making his appointments, any adverse events? You do have injection site reactions, usually for the first couple of doses, then those tend to dissipate. And then again, ongoing mental health evaluation and follow-up, checking to see how he really feels. Has he achieved that freedom from internalized stigma?
Thank you very much to our faculty, and thank you to our listeners for joining in. As a reminder, to view the full program, Contemporary HIV Treatment and Prevention 2024, on the Clinical Care Options website, click on the links in the show notes for this episode. To access all of our new podcast episodes, subscribe to the CCO Infectious Disease podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.